More people, less time. Let's make it happen. Okay, so the starting point is the same. We want decisions, so need to understand what's there and where we want to get to. My starter question actually is basically based on the last discussion. Last discussion we concluded that yes, we more or less understand what is needed from the data perspective, but the big decisions come from the policy level, from the bigger healthcare goals. But going back, so what have been the 3 most important principles so far that Estonian healthcare system, from the health information system and digital health perspective, what principles have we been using, which has been like a success for us? Like everybody can point out a few if they remember. What principles have been there always, most of the time, and which has brought us to this current model that we have right now?
Well, I can start from the regulatory side. This is only thing almost that I know. But historically, actually, the legal basis for using the data in healthcare has been the law. So we don't require really consent, which has been like a revolutionary for the Europe. And I think it's still revolutionary. On the other hand, so we have, for the secondary data use, we also don't really rely on consent. This has been debated in EU, but maybe it was also a good decision. But at the same time, if you consider that consent is, I would say, the far most flexible instrument, then maybe today we actually need to reconsider that sometimes consent gives us more opportunity to move faster compared to the legislative legal basis prescribed in law, which always requires going through the parliament.
Okay, so consent thing, Jaanika.
Yes, I would still come to very basics. I understand that it's about healthcare, but it's also about the infrastructure. So definitely the foundation, meaning the X-road, the ID code, the once only principle. Because without them, we wouldn't be able to connect the systems, we wouldn't be able to identify the patient, and we would be duplicating data all over in different databases, which is a problem for many countries. So still, we have so great architecture, and I so often start my presentation from thanking the guys who actually made it happen 20 years ago, because so many countries are struggling with these basics.
Very, very good. So X-road, it has worked for us. Authentication, maybe we can add here. We have the legal basis. What else has been happening? So what about standards? What has worked well so far?
Maybe I will continue. So if you look at the core of the system, then it's the aim was that we're going to build something that's patient-oriented. I know we talked a lot about the clinicians and the lack of resources there, but still the health information system should support the patients. They should own the data. They should know what kind of data being collected about them. So this is, I think, the principle that we still need to follow. We see that aim or demand to our system is growing. So then we need to keep up with the same pace. So then, and we saw that last patient portal, for example, was not good enough. Now we introduced a new one. So there's more and more questions come into it. So why do we store such data? I want to see more and more and more. So I think this is important, the backbone also of our system that we need to keep in mind.
Anything from the financer perspective?
I didn't think of an answer from the financial spectrum right now, but I would say what I would add to this list is the obligation to share health information centrally. So whatever form it is in, I think Estonian huge win has been that we have data from different institutions all centrally, so the patient and the other specialists that see the patient can access it. We see this as a very normal thing here, but when we visit around, not even far, in around Europe, like in Germany, I did my medical exchange, that same normality that we have here is missing. When you go to another healthcare provider, there's no information at all besides the patient's words. So I think that's been definitely helping us further.
So, anything to add? No? Okay, sure. So, I will go forward now. So, Jaanika initially started that we need to prioritize. We have little resources, but we need to prioritize. So, are we basing this prioritization right now on the principles that we have built up the initial system on? Is this, or does it sometimes happen then we have become quite like well-doing country that we start to think that we can do everything and still add a bit too many things to the list that we should do now?
Yes, it's quite the challenge basically that to say what we won't do. And it was the biggest challenge actually that we wanted to do everything. And when we looked at our promises given by our government during very many years, there are like so many different things, and then start cutting down basically that yes, it's important, but we won't do that. So definitely prioritizing or downscaling has been an issue, and explaining, yes, it's important, but we just don't have the resources. And actually rethinking the whole model of the healthcare information system, meaning shifting to FHIR and shifting to model-based system. And it's like a quite big shift in the whole way of thinking. So definitely the priorities is not about what we will do, and we will do million things, but how to say no to the things that we will not be able to do, even though they're important and even though lives rely on that. And it's very challenging also to find the right KPIs. How do you prioritize? Meaning, how do you prioritize by lives saved, by years saved, or what is the right KPI for the whole system? I would
touch upon this a little bit. So previously, in the previous panel, we concluded that, we concluded several things. But one thing was sure, that if we want to move forward with several standards, we need to have way more resources. And you mentioned modularity, but Jaarika presented this in a bit more detail. So can you explain a little bit this new modular concept that you presented, that is an idea? Understand there is not the plan yet how to go there, but there's a vision or an idea. Can you explain it a little bit and maybe point out where we are changing the existing Estonian healthcare principles and where not? Or does it build on the existing model that has worked for us so far?
I think the main principles that we shared or listed, answering your last question, they definitely remain. These won't change. Probably like the consent part, the main architectural components that we have, the principle that we share all health data, these won't change. These will stay the same. Our question today is if we accept the limitations that we have today, that I presented in the morning and we actually heard in different presentations, or if we accept those limitations, then we will start getting answers. We can do 1 or 2 projects a year. We can change a law or 2 in a couple of years. We have very many restrictions today. And this question is right now, if we want to build the new, we build up capabilities, how to tackle the constant growth of needs, the constant growth of shortage of workforce, etc. Do we take something, do we envision something better, some more capabilities, or do we stay where we are? This is the simplest question. There is no easy answers. There's no easy answers. I can't say exactly what will happen. We will need a plan. We will need the first goals to reach. This can't be that whole, if you remember the picture I showed you, then this can't be that whole thing in 3 years. But we need to have a vision towards what we move to. And that is important in prioritizing as well, because each and every new development that we take on, we can already build upon that vision, so that this growth won't be today, we're in the past, tomorrow we're in the future, but we need to build step by step upwards. Or we can stay where we are. That's always another option.
Are we saying where we are? Right now, North Estonian Medical Center, you're implementing, or you have been working on implementing a new, like putting in place, implementing a new EHR. So constantly work has been ongoing on that front. How do you, like listening out to these conferences, we have many opportunities. We have many challenges along the way. So from a healthcare provider perspective, your job to make sure that regulations are met, doctors are happy, patients' data flows, like what to take from this?
I mean, like if everybody would be very happy, then we should continue on paper. Because from the IT perspective, we can see every day, and I assume it's the same in other hospitals as well, that people have become more aware. They know how to use the data. They have seen what other solutions there are present in other states and so on. And then we fall down to the quite simple task that, for example, the main system in our hospital, it was started around the same time I went to the first grade, so more than 30 years old. So I personally believe that we need to have the disruption that the old saying, what I faced when I joined almost 2 years ago, is that we have done the same and the same for 20 years and more. And this is kind of like the attitude that doesn't allow us to do any changes. So for myself personally, yeah, the disruption is the most important thing. And after that, we can think out, I don't know, whatever solutions the customers actually want.
Yeah, so you're suggesting some kind of thinking mentality disruption, or
yes,
or you're thinking about the total system overhaul, or
it starts from the attitude, I believe. Like the same, like we have used to do it 20 years in a row, the same way, exactly the same way. And yeah, when I joined, like I had to argue that I have also been in the university and done my master's thesis and so on. But the situation and the ground is kind of like I am the doctor, I am the most important one in the organization, so I'm telling you how to do it. But the hospital or the others or the whole sector doesn't work this way.
And just a quick comment. I think the thing starts with the disruption in how we think. We actually, I think, in Tervisekassa and TEHIK have like passed a little bit that thinking pattern, and in Ministry of Social Affairs, the thinking pattern, but then we face the limitations where we are today. So we want to do it better. We want to be able to scale. We want to be able to speed things up. But there are limitations that we need to tackle to make this happen.
Okay, and so we are like thinking of like a way bigger overhaul of the change. But what often comes in is that when we plan many things at the same time, then there is indecision. This means that the existing system still needs to work somehow, but the existing system doesn't understand where's the future that it's going towards. So let's take like an IT vendor currently, whichever one in Estonia. So currently we're talking about FHIR, we're talking about OpenHR, maybe even OMOP. TalTech adds their Consus, so a bunch of standards that we should think about. Then we're talking about some centralized end-user solutions from Tervisekassa, some from TEHIK, and we're talking about in e-health strategy also about, in some part, more prioritization, in some part, more centralization. So, and the messages are quite mixed. This happens in healthcare often, but what should this IT vendor who like listens actually wants to be a good IT vendor for the doctors, so doctors say, okay, let's figure out this new process for this whatever rheumatology pathway. Let's add some standards. Let's talk with people in TEHIK and other places. Let's improve something. But if the decision making is not there, then they are like wait, but maybe the future is going to be different. Does it make sense to invest right now? So, like, how to come over this problem that there is a little bit of a paralysis right now? How to solve this?
I would say from, well, my background is dual actually. So I have a regulatory background, but at the same time, I'm currently leading Health Founders Estonia, which is a government-backed accelerator program for health tech startups actually. So, what I see there, that to be honest, our small startups, they don't really think about it, whether FHIR or OMOP or Open AHR. So why they don't think about it? They first think about how to put their solution to the market and how to survive. So they really think about this first, I would say. They also think about how it would be possible to pilot in Estonia. How to show that there is actually something working, happening. This is the second thing, I think, what they think. Of course, they should think about standards as well, because their ultimate goal is not to stay to Estonia, but to move further, yeah? And if we think, well, we can think like that we should maybe have like a government who says to us that, hey, you should guys all use FHIR or something. But actually I was thinking in the meanwhile when we had all this conference here, and then I was a little bit analyzing this MDR at the same time in my brain, which regulates also the software as a medical device. Yeah? And there is a concept, state of art. So it means basically that software as a medical device developer should always not do less than is state of art. And actually FHIR is already a data exchange standard that we can call as a state of art. So we shouldn't actually do less as a startuppers. This definitely what I'm preaching about, but whether they will do it is another thing, because they first think about survival and piloting. So this is my answer, maybe. Okay. It's not exactly, but...
Yeah, well, it connects up, because we're talking about new functionalities, that doctors need better tools, need new tools, patients need those tools. And then where those come from? Yes, sometimes companies build them, young companies, they try to get to the market. The numbers are not great on that front in Estonia, small market, difficult market, so on. Then the other possibility is the existing vendors. But this example I just gave, that they might be a bit paralyzed if they don't know if some parts of the system is solved at the central level. And then finally, we have a lot of activities ongoing actually at the central level. So I could name just a few examples. I think it's... well, the list is very long. IVF, use case, organ transplanting use cases, procedures, e-consultations. There's a huge list that piles up TEHIKs and knowledge, but then again, not only TEHIK, Tervisekassa, social affairs, and all the system players there. So there's a lot going on at this level, and is it sustainable in this current model? Young startups can't go into market. Big vendors are might be hesitant a bit because they don't know where the system is heading at, and a lot is happening on the central level.
Well, I think actually we have a pretty innovative e-health strategy in regards to have indicated very clearly down to activities what we're planning as a ministry. That means basically that what are our priorities, what we would do, and what are not in our scope, which means private market is extremely welcome to do that, and we will integrate them with the central system if they're compatible. That means that basically we have indicated what is expected from the private market, haven't seen this strategy or approach anywhere. Meaning, for example, where we talk about telehealth, we don't create the solutions. Minister of Social Affairs, TEHIK has no eagerness to program new telehealth solutions, but we need them. And this is why we indicate in strategy private market will step in. In regards to IVF systems and so on, it is also one of the clear benchmarks set in our strategy, but we don't program them, which means that still the private market is a significant player by procuring it. The private market is part of it. And this is why we actually compiled the health strategy to say these areas are priorities. Please participate. We will support as we can by creating the legislation, by piloting, by supporting these areas, while we don't compete with the private market. That means we don't create in parallel solutions, but we extremely much want to support the startups that are matching our priorities. And this is why I set the list of priorities.
I'm going to try to answer both of your last questions together. What would be the guidelines for different new IT vendors? I think making sure that we know which standard we use for what and which are in place is very important for them to be to start on the right foot or know what to expect. So I think that decision is one of the first steps that we need to actually make or clear up. How many of the standards for which purpose do we use here? And then from there on, as you listed, there are so many initiatives that the state is trying to solve. They probably, we need to prioritize which problems need solving. But that model that we talked about in the morning will actually let or give more options to the private sector as well, that we define what we need. And then it will be easier for the IT vendor to choose where or which products to develop. So I think that it can be viewed from different points, like the state is taking away our possibilities, or vice versa, the state is trying to make it clearer for us what is needed. And I think these models that we talked about in the morning can be either we are buy services, IT services as programmers from the market, or whole products, which we do not enough here, but we need to state the rules so that the private sector can start getting ready for the future, and also the government can put their resources in the right places for making those rules actually stand and give answers that the private sector needs to build their products.
And then again, sorry to hop in. We don't want to decide on behalf of private sector what to do. The business model needs to be sustainable from the private sector. That means we can indicate, and what is more important, we can integrate with our central system. We don't decide whether the dermatology is needed or migraine is needed. We can enable them to integrate by certain rules, and the patients and the doctors will choose what to use.
I think you described the existing principles of the Estonian Health Information System. So integration protocols, X-road standards, currently CDA documents, but we can move to FHIR. Yeah. But yes, please, Roman, when you listen to this, and then I would ask from Jaagup, so is it like this right now? Do we have guidelines? What information is missing?
I think when someone asking me about the priorities, then I'm answering always, what about them? So this is what we see today, is that we have so many different initiatives ongoing, as you mentioned. So there's some logic behind of it. It's a huge lack of resources that we have. We have some resources. The lack of money, funding, and so on and so on. Then you need to make a decision faster than maybe before. But what we are missing today is the clear message to the private sector, what we're actually aiming for, what kind of guidelines should they follow. Also, we need to have our own strategy that we need to come back every time when someone is coming with some great idea that do not apply to our strategy. I will bring some example. Every time when we decide today to create a new service that is working based on CDA documents, we create technical depth in our solutions. This is some decisions that we're actually doing every day today. So you need to be excellent in saying no to the customer that no, we can't do that, because this is something that you need to redo once again, maybe in the future. But then you still need to understand why they need that today. So it's really hard discussion today. But at the same time, if we're aiming for the bright future with FHIR, Open HR, if we really believe that we should stick to the plan. This is something that I see. So, that's about the priorities. Yeah.
Maybe just to connect this a bit. We need to stick to the plan, and then you brought up CDA documents, and then I remember Jaarika's slide about we need to do a development 8 times. And when you mean by this development 8 times, this probably means that when a government suggests some kind of centralized standard change, then this happens 8 times. Have the system looked into the cost of these adaptations and integrations, what come from the top? So, Jaagup, like, do you, like, when something comes in, new epic crisis, let's say for like hospital drugs or something like this, how big is your stress level then, and what's your plan? How to solve it?
I'm not stressed at all. I mean, like, in general, as I've seen now for like 2 years, some change actually should take around 3 months. 1 month is to get the initial like paperwork done. Almost 1 month is to talk to the customers that are you really interested in getting some solution and so on. And last 2 weeks is for the development. But this, I believe, needs to change that. We can't survive in a way that we spend like months and months for just arguing about some teeny tiny technical detail. I would like to see more like agile way of working here. That's like Roman mentioned briefly. If something doesn't work, then it means that the previous solution wasn't wrong, but it was done on the level of facts and details that was known before. So just redecide and go further and explore the new options and so on and so on.
Are these discussions happening on premise with your local doctors and your system, like your developers, or do you mean discussions at the central level where there is all the different vendors and so on? So which discussions are you referring to?
Depends. I believe it like depends on the topic. There is one quite good example from the previous quarter to get the new price list updated regarding the ER pricing and so on. It was like laid down very, I would say almost like perfectly, that which usually doesn't happen, that there are requirements. We didn't have the solution ready back then, but it actually started to work in parallel. Like, first of all, the requirements were agreed between 3 different parties, like hospitals, TEHIK and Tervisekassa, and the ministry, of course. And after that, basically the development work started in parallel in all those areas, which actually finalized almost at the same time in the testing environment, so that finally then all those like puzzle pieces were actually put together, and it kind of like worked.
I would like, because the time is super short in this panel and we're just getting started, but there again. We have this broader vision by Jaanika and Tervisekassa, where we have like a separated front end and back end, and there's one API, and it's it's still an idea and the plan, and we're not fully sure if that's the way to go. But at the same time, we have an existing system, and rightfully so, that we need to integrate through these integrations, right? So what could we do in order to just make this kind of example easier? In any case, even if we build like a totally new parallel system, then we need to keep up the existing system, right? So like how to make all of those adjustments, which like 8 times cost, how could we make it 4 times cost or 2 times cost? One example brought up is event-based, losing CDAs, event-based fire protocols for integration with Tervise infosystem. One example is also maybe there are some governance opportunities. So assuming we have to go, basically zero budget, nothing will change. We have to go forward in the same way right now. So like there's no money coming in extra. We cannot make investment, whatever can happen in the world. So how would you improve the current model's cost efficiency so that all these decisions, all these central changes are done quicker? Even though talk about startups and young companies who are just up and coming, and we're like like how to make the existing system work more efficiently, so that if there's a change needed, it gets updated, and all the different vendors are not like. Shh. Yeah,
I can go. There are quite. Actually, I would say like there are too many exceptions that we need to take to account to do the developments, to find out what changes we need to do. We can't continue in a way that every human being in the sector actually can get what they desire or what they want. There is no, simply put, there is no time for us to use the money this way. We will get bankrupt in such way. I mean, like, if you need to register a patient to the hospital, there are clearly like the same steps you need to do in every hospital. So why don't we just unify this and apply the same approach to all other like processes inside the hospitals?
So it's more about governance. Yeah, Jaarika, do I agree? And, can you give an example how to like just improve the current model if we have no money to change anything bigger? Like, and we doesn't mean that we have to like we can still use Open EHR, Fire, and OMOP. I mean, they're free to use. So.
Mm-hmm. I'm really struggling with a good answer, because what would help would be constant communication with all those 8+ vendors and hospital partners, but investing all our central resources in communicating all of those changes. For example, Roman can say which standard of CDA documents was it that Medisoft still used in primary care practitioners' main IT system, which is like 6.
Version 4.
And we are at 11 today. Mm-hmm. Like all these changes that we do centrally to improve something, they all need to be taken to the very last or pushed to the very last end to make sure that they have been actually done in the systems. And this is huge amount of central workforce that we would need to make that happen.
Jaanika,
to do it ideally.
Thank you. Jaanika, anything in the e-health strategy? I'm aware of the time, so I cannot go forward with the answer.
There is never zero money. Yes, besides kind of increasing the efficiency, I do believe that there is basically money out there, and we need to learn how to attract it. We cannot continue by changing the ways we invest Tervisekassa's money. We need to figure out new ways, which means private-public partnerships, which means the EU funding, which means long-term investing, which means private sector, and so on. So zero money is if we have this only government purse, but we don't have. We need to learn how to engage the investors and long-term investing and funding.
We can answer the one how to make this existing.
I understood your exercises. There is no money coming in, so we need
more money.
Yeah, more money. So we need to keep the base. So I'm coming from private sector, so I know what's actually the pain or what actually you're seeking for. So then here is the same as that there is always some investments that actually puts to get something that business need, but there's always OPEX part. So this is something, the huge amount of money just to keep the system up and running. So if we look again, maybe I will just speculate, but it's something today around 50-50. So that means that what are we going to do with the legacy systems that cost us a lot? Do you know how much documents actually stored today in health information system? It's 200 million documents. If you put that into the money, so then can we, if we divide that in a data, can we gain some, I don't know, some additional money from there? So this is something that also we need to practice even more. So can we save somewhere money and to put that more into the investment, so we can give it to the private sector and then to make something better. So this is something what I see is that we need to be excellent in the understanding where this money goes or stays, so to utilize it more.
So I have a twofold answer. First of all, our parliament members are still getting paid, so this is good news. And therefore, we should kind of check into the e-health regulatory frameworks as well, how to deregulate there. Because we have Finland, for example, our next door neighbor, and they don't have government regulation stipulating all the data points that we collect. And they can do it. And they operate in the same legislative arena, EU, GDPR is the basis. And they have managed to make it more flexible. So our neighbors, they know how to do it. Why don't we just ask them and make it the same way? And parliament members, they get paid and they should actually solve it. And second thing is to come to you. I said, coming from the private sector, I always say that if you don't have enough money, then sell more. So you need to find a better way how to make a business. So we should really build in Estonia such solutions, even in a level of state and governmental level, that we can scale and sell outside. We shouldn't deal with the stuff that are only local. And so that's my answer.
And thank you. And these existing solutions know that open EHR is important to get by, and EFI is important, the OMAP is important, and so on. So I think the time is up. Yes, the time is up. So I will just summarize it. More money, existing cost efficiency, potential mentality change, potential total system overhaul, but needs a plan and the priorities. So thank you so much for this panel discussion. And as always, discussion in healthcare continues everywhere, constantly. And I hope you enjoyed the panel.
Thank you.
Thank you.
Thank you very much.